Understanding group dynamics and developmental stages is only useful if you can translate those principles into the room. Theoretical knowledge has to become actionable execution. Many new facilitators assume their job is simply to deliver clinical information. But standing at the front of a room and lecturing fails in a clinical setting because it treats clients as passive recipients. Adults do not absorb clinical material just by hearing it. They retain new concepts when they actively participate and explicitly connect that material to their own lived experiences. To drive this engagement, a facilitator has to deploy specific interactive mechanisms. You ask targeted questions. You invite members to share personal examples. You use brief exercises and initiate discussions that require the group to do the analytical work. In skills groups, you have to push beyond discussion. You have members physically rehearse the target skill inside the room, whether that means role-playing a difficult conversation or practicing how to refuse a substance. This physical rehearsal allows the leader to provide immediate coaching and real-time feedback. Clinical skills are built through this exact kind of physical repetition and guided practice, rather than just through explanation. If you are talking uninterrupted for 50 minutes, you have run a class, not a group. Therapeutic change requires the active participation of the members. Delivering clinical content does not mean the group actually learned it. There is a persistent cognitive gap between a clinician presenting material and a patient successfully absorbing it. To bridge this gap, you have to regularly check for understanding. You cannot assume that therapeutic material landed exactly as you intended. This means asking members to perform cognitive translation tasks. You might ask them to put a core concept into their own words, or explain precisely how they will apply a specific coping strategy in the week ahead. These checks act as an early warning system. They immediately surface hidden confusion or disagreement, allowing you to address the disconnect before the session moves forward. In purely skills-based work, the physical rehearsal itself serves as the check. The question isn't whether the member understands the skill, but whether they can actually execute it when prompted. By running this constant loop of verification, you transform a one-way transmission into genuine learning. Once a session is underway, live facilitation requires a state of constant low-key management. Your primary job is to keep the group on track without steamrolling the individual needs of the members. You monitor the room, using gentle invitations to draw in quiet members. At the same time, you contain dominant members, ensuring fair airtime. Instead of routing communication through you link members to each other, building peer interaction. But there is a critical exception to the structured agenda. Sometimes the planned topic must be abandoned to address a sudden crisis or a spontaneous emotional eruption in the room. This is the ongoing calculus of facilitation, weighing the acute distress of a single individual against the functional needs of the collective group. When done well, good facilitation looks effortless to an observer, precisely because the leader is executing dozens of these invisible micro-adjustments simultaneously. The facilitator's job does not end when the session objective data points. First, their attendance, the day's clinical focus, and the specific member's response. However, you face an absolute mandate to protect the confidentiality of the other group members within those individual notes. A chart note about one specific patient must never expose the identity or detail the personal disclosures of anyone else who was in the room. These notes serve a dual purpose. They provide a record, and they explicitly tie the isolated group session back into the overarching treatment plan. Writing clear, objective, and confidential notes is a clinical and legal necessity. You prepare every entry as if scrutinized by a supervisor, auditor, or court. New facilitators rarely invent new mistakes. Most group leadership failures fall into predictable, systemic traps. The most common pitfall is facilitator anxiety. To control the room, a nervous leader will overtalk, defaulting to a lecture rather than managing live interaction. Another trap is conflict avoidance. When a leader shies away from tension in the room, the group dynamics remain shallow. Structural failure also occurs when dominant members are allowed to dictate the flow. When one person takes over, the quiet members often disengage. Then there are boundary failures, like neglecting the final closing phase. This results in abrupt endings and a loss of time management. Finally, there is the failure of leaving the therapeutic material abstract, preventing members from connecting it to their actual daily lives. The antidote to these failures is disciplined structure. You set clear objectives, protect fair airtime, maintain strict clock management, and speak less so you can facilitate more. Excellence in group leadership is not an innate personality trait. It is a deliberately built skill set. With the proper consent, recording your sessions is critical. It exposes the behavioral patterns and blind spots that you cannot see while you are actively managing the room. Clinical supervision and co-facilitation provide external feedback loops. They give you a structured space to process difficult sessions and plan improvements. This external feedback must be paired with honest post-session self-reflection to evaluate what the group actually needed versus what was delivered. The core architecture of a successful group relies on these specific mechanics: prepared objectives, interactive delivery, dynamic live facilitation, and confidential documentation. Mastering these mechanics is what turns theory into a repeatable practice, ensuring the session functions as a reliable environment for member development.